Thank you, Dr. Chauhan. I think we must begin to Dr. Chauhan, who is doing every week for us, this taking problem for us. So my job is very easy. Dr. Vineet Malhotra, everybody knows. I think he is one of the best urologists in India and definitely in Delhi. And everybody must have used his skills for his patients or his relatives. So he is a MCH urologist and his special interest in andrology. Everybody, we know that he has all urologists, they are not interested in andrology work. They may be doing QRP, PCNL, but he takes time for his andrology patients because the andrology is a branch which needs extra time. He has to devote some time for those patients. And today's topic is BPH. It's a very common disease, but he will speak on the latest treatment in BPH, particularly non-surgical management, and when we come to surgical management, what is the latest minimal invasive surgical treatment for BPH. So I hand over to Dr. Vineet Malhotra, a very smart and very efficient urologist. Dr. Vineet, please. Please give him a weekend.
Friends, the Cipla marketing team will take some photos because they need to send it to their HO. So can I just ask you to keep your juices down, all these yellow colored juices down for some time. And and then once we are finished with the photograph, you can do whatever you want. When you are comfortable, please take the photo. Kindly do as I said. Dr. Poddar, please keep it down for some time, sir. Only for a minute. Dr. Manohar, Dr. Sudhir Kapoor, sir, kindly keep it down, sir. Keep it down, sir, please. Thank you. Just for a minute, sir. Just for a minute. We'll take photographs and then you can go ahead. Dr. Vineet, sir, please. Bhai, photo le lo. Aap photo le lo.
Thank you. Thank you for the kind introduction, sir. We'll begin with this because I know this time it's always nice to be back with the Physicians Forum of India and all of you. We'll talk a little bit about the newer medical therapy and then talk about some newer minimally invasive treatments available for BPH. So, to understand why are we talking about this? As we see therapy becoming better, whether we are talking about any kind of treatment, now we are looking at a lot of patients that demand quality of life. This was something we never bothered about at some point in time. And now we are talking about a lot of patients that will, will demand a quality of life. So when you get a patient that's got his lower urinary tract symptoms, it's not just the fact that you're going to treat his prostate, you're going to make his urinary flow better, and the fact that you'll probably relieve him from obstructions, recurrent infections, but also what are you going to do about his quality of life, and in doing this treatment, how much are you going to affect his quality of life. So when we spoke, and I remember this from patient episodes, I remember very early on in my practice, I used tamsulosin for a patient, and he came back furious in the next visit to me. And the thing, and I was early in practice and I had not realized what had happened. And he said, how did you not tell me about the anejaculation or the retrograde ejaculation effect of tamsulosin? How could you not tell me this, that after I take this medicine, I'm not going to have an ejaculation? And I realized that yes, I had missed telling him one of the side effects of the medication. And it stayed with me because this is something that's important. This is someone who demanded that his quality of life, if it's getting affected, he had to be informed. And now, it's a habit. I will tell patients about how their quality of life will get affected, whether I'm using medical therapy, whether I'm going to do a surgery. And thankfully, there are things now which are going to make this difference. So we know that some of the points that I'm going to run through are indications for medical therapy. You know patients that have poorer streams, they have altered bladder sensations, frequency, nocturia. They're going to be those patients that you're going to advise some kind of changes. What are the changes? So nowadays, everything begins with lifestyle modification. Again, it's become a very important factor, because when you talk about quality of life, you also talk about how what lifestyle they lead leads to what conditions. And this will become very important, whether weight loss, whether you're looking at exercise, reducing the fluid intake, even the temperature of the fluid intake. So we know that if someone is used to taking very cold fluids, he's going to have more bladder frequency, and if he's going to shift to warmer fluids or more room temperature fluids, his bladder frequency will reduce. So simple measures also in lifestyle changes will make a difference. But the mainstay is alpha blockers. Now, how has this changed recently? We've started using PDE5 inhibitors for their role in management of BPH. And when this happened, it was realized, again, this is a quality of life issue. I again remember a patient that came, and he was in his 70s, early 70s, and he said, I'm sexually active. So, if you're going to ask me about my sexual habits, yes, I'm still sexually active. So, again, a point which I realized was that I should not be judgmental. This is a question that I have to ask and not assume. So that became a habit too. So now even if he's 80, I'm going to ask him, are you sexually active, or are you going to not be sexually active, so that I know what kind of treatment I have to offer you. I've implanted a patient who was 84, so patients can be active at any age. And this habit of using the PDE5 inhibitors came with the same concept, that you get two benefits out of it. You'd have someone maintaining his sexual function and getting relief of symptoms, and that's where now there's been a slight shift of concept. Monotherapy alone is not considered adequate in a lot of cases. In fact, sometimes we use 2 alpha blockers to give relief to the patient. And instead of using 2 alpha blockers to actually give that relief, what works better is when we are going to use agents, one, which will preserve sexual function, have less ejaculatory disturbance because you can modify the doses and bring down the dose of the alpha blocker, and then result in the Qmax reaching the normal range. So the combination that has come for most of these patients, it requires a longer acting agent. So you can't use something like an avanafil or a sildenafil for a long term effect. We know that the duration of action is 4 to 6 hours. So you use something which has a duration of action which is much longer, along with tamsulosin or alfuzosin, which has a duration of action of almost 24 hours. So that's where it's been shown that tamsulosin plus tadalafil will achieve better flow rates. They will alleviate the symptoms of LUTS, will increase or improve the IPSS, and have a very low incidence of adverse effects. So they're safe for use in patients with metabolic syndrome. And with all of this, they will have a beneficial effect on sexual function. We know that a lot of men with LUTS will have their sexual function affected, which means erectile dysfunction incidence will be higher, and hence this combination therapy will work very well in these patients. And even the treatment that I'm going to talk about today actually follows up on how we can preserve function. So the multimodal action of this synergistic vasodilatation is that it's going to upregulate, this is that pathway of PDE5 inhibitors, the cyclic GMP pathway, and modulate the NS activity, overactivity, reduce the nocturia episodes, improve the LUTS. The tamsulosin will have the relaxant effect on the bladder neck, and together they'll be able to give a synergistic effect on both the bladder neck, and a tertiary effect on the sexual function. And this has been proved by all the recent guidelines. So AUA guidelines, EAU guidelines, these guidelines, all of them now recommend that you can use a combination of alpha blocker with a PDE5 inhibitor to alleviate symptoms of LUTS with BPH with or without any sexual dysfunction. So one second, sorry, yeah. And now we'll come to the minimally invasive treatment. So that's one new concept that's come. And the second, so I've already spoken to you about URILOFT in one of the talks that we did. And I had one of you asking me today as to how the URILOFT is doing. And I said it's a matter of chance that there are now 2 more therapies that have come in during the same time in the last year that have become popular. And they're all minimally invasive treatments. They all come with the benefit of practically being done without anesthesia, with local anesthesia, and they all have brilliant results. So now it's become a comparative between these 3 therapies in terms of how less invasive it is, how more effective it is, and in our country, how much does it cost. So that's become the bottom line of how we're using these therapies. REZUM is a therapy that I'm doing a lot. In fact, I'm happy to share with you that I'm right now the only surgeon in Delhi that's done about 20 cases of REZUM. This is it was Israeli technology, now owned by Boston Scientific US, and is an extremely effective therapy. So we actually will see, this is a water vapor therapy, steam therapy. What it does is that it dissolves the prostate with steam injected through needles in the prostate. No side effect on ejaculation, no side effect on erectile function, and it is a slow process. So it's not like you'll have visually immediate effect, but over a period of 3 to 4 weeks, the residual prostate is less than 20% of the original prostate size. And we can do prostates from 30 grams to 80 grams for REZUM. So it uses these 3 different ways: heat source, heat transfer, and targeted treatments. So what is going to happen is that you're going to give targeted treatments to different zones of the prostate by injecting these needles. So I'll just show you how this needle will cause a rapid and uniform vaporization. So you can see that once you've injected, this is the needle that is injecting into the prostate gland itself, and once you've injected, you're going to see steam being released into the prostate and vaporization happening immediately and thereafter also. So that's the effect of the steam that's going to happen. And the beauty of this is that the entire procedure will take less than 10 minutes. This is done under local anesthesia. Sometimes we use some mild sedation. And it takes, so one session takes 9 seconds. And you have 4 or 5 such sessions, which means needle, after you calculate the distance, we inject at 4 or 5 places. There's a rule to injecting this with the needle, which means we actually measure from the bladder neck and we identify 1 centimeter and then at 2 centimeter and then go laterally and inject into the lobes. And you inject only for 9 seconds. That's the vaporization time for the needle. And we are able to do this for 4 sessions, say over 36 seconds. So the entire time for the procedure practically lasts for 5 minutes or 7 minutes, and that's the treatment time. Patient's treatment is over and done with. There is one flip side to this. So you're seeing outcomes also. Outcomes are very good. Volume, so you're looking at volume reduction, which is significant in these patients, both seen at 1 month and 3 months. And you can see how the lobe has disappeared and how the gland is opened up at 6 months. So we actually recommend patients that don't look at your outcomes only at a month only, because you will find the overall result coming to you at 3 months, because it's so minimally invasive that this becomes a very, very useful for patients. And again, there are a variety of studies that have been done. As I mentioned to you, patients that were greater than 50 years old, you can do it in patients that are younger. In fact, one of the indications that has been used for this is those patients that have bladder neck stenosis. And essentially for patients that have prostates within 30 to 80 grams. We have still not started to use this for patients that have a prostate size higher than 80 grams, but it's very useful for those that have prostate sizes. And outside this country, there is data which is available for 5 years and greater. In India, the data is still recent. The first time I'd seen this was back in 2014. That's the kind of time it takes to translate treatment which has been introduced in one part of the world to other parts of the world, because that time it was Israel only, and then they introduced it in the US, then US FDA and all of that, and it's taken almost 10-11 years before it's coming to India. And they've seen and they've treated patients that have prostates between 30 and 80 grams and had a excellent improvement in terms of significant improvement of IPSS. You saw a significant severity score of 22 dropping to 11 and a Qmax from under 10 going and stabilizing at between 13 and 15. Sexual function, again extremely important to see that the sexual function reported no procedure related side effects on ED and no impact also on ejaculatory dysfunction. So this completely differs from patients that will have say a HOLEP or a TURP where you're going to see significant sexual side effects. So there is proven durability for treatment of BPH, there is improvement in symptoms of LUTS, and currently they've had 5-year data which has shown this ability to treat prostates with lateral lobes. Positive safety profile, it's extremely safe. You can practically use it on all patients that you can think of because this is a needle-based steam therapy and it preserves sexual function. You should be doing it in patients that have obstructive symptoms, those that are greater than 30 centimeter volume. You can't use it, unfortunately, we can't use it in patients that need a sphincter and implant. So what do we do if they have to undergo a procedure? Is that we do a REZUM before they undergo an implant or a sphincter so that they're already treated and will not require it post the procedure. So that's the REZUM system. This is what it's a very simple tabletop kind of thing, and that's the gun which has the needle. And it's an 8-step procedure. This is how the delivery system looks inside. That's the needle firing the needle inside the gland. That's what the needle fired looks like. And eventually you start the treatment from 1 centimeter from the bladder neck and you come closer to the verumentanum and then treat the elevated median lobes at the end of the procedure. So the only flip side to this procedure is that you require catheterization for 6 to 10 days. I'm usually keeping catheters for 10 days for patients because they may have some amount of sludge, prostate sludge, that will wash out over the next 7 to 10 days. So they have to be counseled about catheterization post-procedure. That's the only flip side of this procedure. So that's the REZUM procedure. Now coming to the other procedure, and this is called ITind, and this is another treatment this is extremely recent. This is by a company called Olympus, and this is even more recent. So what you see here is a spring kind of mechanism at the end of a gun. Now what this ITind does is that it cuts the prostate and opens it up. And this spring is placed inside the prostate for 7 days only. So it's a temporary implant. Now this is the results that we have for this are shorter. It's shown to be effective for a period of 4 years. But the benefit is that you can do it under local anesthesia even in a patient that is seriously ill. So if you are looking at a high-risk patient who does not wish to have a catheter or you don't wish to keep a urinary catheter on him, this is an excellent procedure because you will go in and put in this spring device just beyond the bladder neck. So this is where you place it. You just bring it here and place it there. And the edges of the spring will actually cut into the margins of the prostate and open it up. And that's called the ITind device. The ITind device is again placed under local anesthesia and it allows, as you can see, it will open up the prostate at that time. When it opens up the prostate, it actually cuts through the lobes of the prostate and eventually they will atrophy from the sides. And it's shown to have a beneficial effect which lasts for up to 4 years. So again, very, very minimally invasive. These are extremely minimally invasive procedures compared to all the previous procedures, even more minimally invasive than the URILOFT procedure. The URILOFT procedure has a permanent stapling implant which, if it doesn't work, is a real challenge to remove out of the system. Compared to the 3 devices, the URILOFT is the most expensive. Treatment costs will usually vary between 4 to 5 lakhs. For the REZUM procedure and the ITind procedure, the procedure costs are somewhere between the 2 to 3 lakh cost. So cost is still a challenge with these minimally invasive procedures, but they are excellent procedures in terms of those that have high risk, those that wish to preserve sexual function, because they have absolute preservation of sexual function in these men. And at the end of 7 days, it's a very, very simple maneuver to just remove the spring from the prostatic fossa. And you can see the prostatic fossa remains open because it is cut into the prostate in the areas where the spring has opened up. And that was the URILOFT, which I had already mentioned to you previously. You've already seen that. So I'm not going to repeat how the URILOFT works, but it's a stapling device. It staples and pulls the lobes of the prostate away. And that's the third minimally invasive procedure available these days. So several newer modalities available to improve and maintain the quality of life for patients that have BPH and loops. Medical therapy, combination therapy of alpha blockers and PDE5 inhibitors has become popular. And there are 3 types of minimally invasive surgical procedures that are now available, which can be done without risk of anesthesia, which can be done without risk of any complications, and preserve sexual function. Thank you so much for your kind attention.
Dr. Prateek, kindly introduce Dr. Mishra.
Now I would like Dr. Abhishek to throw some light on the very important aspect of the orthopedics complicated problems. Many of the times, everyone feels and patient asks whether the surgery is required or not in this kind of fracture or in some other type of chronic pains. So it becomes very difficult for the physician or surgeon or the patient to decide how to proceed such cases. So regard like fracture, whether they are associated with any nerve injury or not, or if it is joint, it is infective or not, or certain fractures which requires surgery immediately. So I think this presentation will open our eyes whether to go with the surgery and pros and cons of the surgery and what will happen if we don't go with the surgery. And thank you and welcome Dr. Abhishek.
Thank you, Dr. Prateek, and it was very good meeting you, and it reminded me of my college days, like MS days. Incidentally, Prateek and I belong to the same chain. It's just that he's quite junior and we know quite a few people. So he reminded me of some of my very juniors. So anyways, So I'll just I try to make this presentation very short and crisp, not to take much of your time, and not to keep you away from the more. हाँ? वो देख लिया वो सर डॉक्टर चौहान का क्रेडिट है। इसका मतलब ये है कि 2035 तक तो आराम से चलता रहेगा इसके। उसके बाद का फिर शुभम को संभालना है। ये बिना पीए ये प्रेजेंटेशन बिना पीए बनाया था, ये गलती से हो गया। Futuristic. So. When I was asked about the topic of presentation, firstly let me re-emphasize, speaking in this forum is like coming back to the family again. This is like, I have been associated with this community since last, I don't know, 12-15 years. Probably I still had hair at that time. But, whatever little I've achieved, I don't know, I've not achieved so much, but whatever little I've achieved, I acknowledge the contribution of many people present here. I would not like to take the names, but some people are like they have been more than instrumental in whatever little I've achieved. Sorry? वो CME के बाद बताऊँ. So basically this was so when I was asked about the topic of presentation, you see, whenever you are asked about the topic of presentation, first thing which comes to your mind is joint replacement, like TKR, THR, use of robotic, non-robotic. But I thought that as a physician, like what should be my preference? So if I'm a physician, if I am asked to listen to something, then it should be relevant to me. And I thought as a physician, we are always like, people are always faced with a dilemma that when they refer a patient to orthopedician, they are always advised surgical treatment. So what are the conditions? It is relevant, it is correct. So this presentation is just about decision making, deciding what are the conditions in which conservative treatment succeeds and surgical treatment is not necessary. So probably today I'll be talking like a physician, more like a physician than an orthopedic surgeon. I'm not talking about joint replacement too much, I'm not talking about arthroscopy too much, just the basics. So surgical versus conservative management in 10 common orthopedic problems. There's so many orthopedic problems, the list is endless. I have just selected 10 with which the patient will come to you, will come to a physician. So some fractures, some degenerative conditions and all those. So this presentation will provide a comprehensive overview of treatment strategy. It will highlight the nuanced decision-making process in orthopedic management. What is our thinking when we decide about a treatment? Whether the patient should be operated or should not be operated, should be left alone, should be dealt with conservatively. Emphasize patient-specific considerations in treatment selection. So most important part of this presentation is the last part. This last part. What are the factors influencing treatment decisions? Patient age is a very, very important factor in deciding whether the patient should be operated or not. Overall health status. What does it mean? It basically means suppose there are two people, both are 80 years old, but one is fit and fit as a fiddle. He goes for exercise and walks daily. And other one is like moribund, like bedridden or minimally domiciliary ambulatory. Then there is a difference between the treatment options or treatment choices in both these patients, despite being the same age. Then overall health status, more or less means the same thing. Functional requirements. What is the functional requirement? So one person who is elderly but who is independent, another person who is elderly, not independent, he is already dependent on his family members or helps for so many things, and his needs are limited. So treatment options would differ. What I am trying to say is treatment options should be customized according to the patient. It's not that one shirt or one size fits all. We have to think from person to person, from patient to patient. Then what is the severity of the condition and what are the potential complications? Another important factor. A very smart surgeon would always know which surgery not to do rather than which surgery to do. Experience is what teaches the surgeons कि कहाँ डालना है, कहाँ नहीं डालना है. So I'll just enumerate 10 basic conditions. with which the patients come to you. One very important, one very common condition with which the patient comes to physicians is fracture of distal radius, like lower end radius ka fracture, kalai ka fracture, with which the patient comes to you. And what is the option of conservative management? We can just give up. Management is done in the form of open reduction internal fixation. When it's an unstable fracture, when there is an intra-articular extension, when the fracture is extending to the joint surface, then ideally we should consider for the surgical treatment. And young active patients, so patient who is less than 50 or 60. Now this term young is relative. A patient who is 70 can also be young. A patient who is 55 cannot be young. It depends on the present functional status of the patient. What are the advantages of surgical treatment? It basically improves anatomical alignment and it hastens the functional recovery. The patient can go back immediately to activities of daily life, and very soon the patient is able to start with all the activities he has been doing. On the other hand, if we delay surgery, for example elderly, then there are chances of this condition called reflex sympathetic dystrophy or Sudeck's dystrophy, which makes the patient debilitated and immobile for many months or years altogether. So these are X-rays which are taken from my own patients, and I've tried to take the X-rays from just 1 month, 1.5 months. Mostly these patients are from VNA. Some patients have been operated at some other places. So this is a distal radius fracture, and you can see this is a young patient. So probably he's 49, but 49 is still young. And it's a comminuted intra-articular fracture. You can see the fracture line extending up to the joint surface. Plating has been done. It has been done just maybe 2 weeks ago, not more than that. And today already the patient is driving and writing and doing all these things. Now I would just like to emphasize one point which is very important in the perspective of physicians. There is something called Colles fracture. And Colles fracture is very different from intra-articular fractures. This is an example of Colles fracture. Here you can see that the fracture line, none of the fracture line is extending till the joint surface. So in Colles fracture, surgery is hardly indicated, almost never. But when there is an intra-articular fracture of distal radius in a young patient, almost always surgery is needed to make sure that later wrist osteoarthritis does not develop and the patient regains his functionality very quickly. Next important and very common condition is fracture of vertebra, and fracture of vertebra is very commonly associated with osteoporosis. So many times it is seen in elderly, most of times, but sometimes it can be seen in younger patients also. So conservative management is just advising patient bed rest, giving a belt, pain management like writing anti-inflammatories and painkillers, rehabilitation. Once the pain goes down, then tell the patient to indulge in exercises to strengthen the back muscles. So this conservative or non-operative management is useful for stable and non-neurological fractures, which basically means fracture which does not have caused any neurological damage. And there is no displacement. Whereas surgical management like vertebroplasty, kyphoplasty, spinal fusion, these are indicated for severe pain which is not being controlled with analgesics even after 3, 4, 5, 6 weeks. Neurological compromise. If there is a neurological deficit, immediately, don't even think of conservative management, immediately advise the patient to get surgery. And significant vertebral collapse. If there is more than 30 to 40% vertebral collapse, then the patient should be advised any of these, either fusion or instrumentation or kyphoplasty or vertebroplasty. Because if there is a significant collapse, then the patient will have a very high chance of getting a kyphosis or a scoliosis later in life, which might make his life very troublesome. So these are the X-rays. Again, these are the X-rays of my patient. This is an interesting case. For this patient, he came from Jharkhand, Ranchi, and I had done his kyphoplasty for one vertebral fracture. You can see his previous X-ray. That was around 6, 7, 8 years ago, and I had to do a repeat kyphoplasty. Now this X-ray is not perfect. There is technical error in this X-ray, but nonetheless the patient is not troubled. That's why I put this X-ray. So this is 2-level kyphoplasty done in the same patient. Incidentally, I had done a THR for this patient many years ago. So this patient is like a EMI. He always keeps coming after 2 years or 3 years and start. But anyways, So one very important and common condition is intertrochanteric fracture of the hip. And this is a very common condition. And remember that in intertrochanteric fractures of the hip, conservative or non-surgical treatment is a relic, is a thing of the past. Thinking about conservative treatment in intertrochanteric fracture of the hip is like thinking about keeping dinosaur as a pet. Don't ever advise conservative treatment in intertrochanteric fracture, whatever age the patient is, 75, 80, 85, 90, 95, I would say 100 also. We have done, like in our hospital, we have done patients who are 100 years old, and we have done treatment of these intertrochanteric fractures, and patients have done very well. So intertrochanteric fractures, if you don't operate, the patient remains bedridden for 2 months, 2.5, 3 months. Patient develops bed sores, patient develops respiratory complications, and that sure is pronouncing a death sentence for the patient. 70, 80, 90% of patients die with intertrochanteric fracture if you don't operate. Unfortunately, in 50% of patients, even if you operate, still they die. But still there is a 40-50% margin that they will survive. So you always explain the patient there is a high risk of morbidity even though you operate, but still the chances of patient making through this condition is more when we are operating. Why? Because once you operate, you can start ambulating the patient the very next day or after 2-3 days. And if the patient starts walking, chances of respiratory complications, chances of collapse of lung, chances of bed sores, it becomes less. And you are giving the patient a second breath of life. Maybe he lives 2 years, 3 years, 4 years, 5 years after the surgery, but those 4-5 years when he's already 75 years, 80 years, still count. So in intertrochanteric fractures, there is virtually no role of conservative treatment, only for those patients who are already bedridden, who already are counting their days, or relatives are like totally against surgery, and you need to kind of push or kind of barge inside the house to take the patient out. Then you can advise conservative treatment. But 99.9% I would say intertrochanteric fracture, always advise surgical treatment whatever the age of the patient is. So again, this is a patient, she's around 70-75 years. Incidentally, she happens to be a patient of my mother whom I had operated for knee. And this is, you can see, this is a comminuted fracture, and you can see how nicely the bone fits in. The fitting of medial cortical line in calca. After the surgery, patient starts ambulating immediately after surgery, and this is hardly, I think, 1 week ago or some 10 days ago. So Janandar Hospital, and this is quite old. 65 is written, but she is around 70. In our country, generally, especially females, they tell their age 5, 10, 15 years before the, less than their actual age. So fracture of femur and tibia, again, one condition in which there is no role of conservative treatment. Always operate. Long bones fracture of lower limb, whatever the age, 65, 70, 75, 80, 85, you have to operate. Why? Again, the same reason, to make the patient ambulate faster and to reduce the chances, reduce the comorbidities associated with being bedridden. So always early, only in those patients who are already bedridden, like somebody who is already paralytic, who has a stroke, who was not walking before itself, who was already bedridden. Only these patients you can say that go for a plaster, go for a brace, wait for 2 months, 3 months, probably it will unite. Even if it doesn't unite, no problem. In any case, you are not walking, you will still not walk. So that is how it goes. But if the patient is ambulatory, whatever the age, you should advise surgery. Fracture of long bones of lower limb, always surgery. So again, so now another very common condition, osteoarthritis of the knee. There is conservative treatment also, there is surgical treatment also. Early stages, conservative treatment. Late stages, surgical treatment. Conservative treatment has failed, surgical treatment. Surgical treatment, age is again not a criteria. Age is not a criteria because these days, even if the patient is 35, 40, 45 years old. Sorry, I would talk about my patients. The youngest patient in whom I have done a total hip replacement was 18 years old. He had a rheumatoid arthritis. the youngest patient in whom I have done a total knee replacement is 24 years old. She has rheumatoid arthritis. So age is not a criteria. It is the disability, it is the pain which is the criteria. So early stage, try conservative treatment, try to give analgesics, tell the patient to lose weight. It doesn't help, go for surgery, whatever the age of the patient is. And these days, revisions are becoming commonplace, revisions are becoming very common, and revisions are not so difficult. So thank you. So when we talk about osteoarthritis of the knee, then age is not a criteria, it is the disability, deformity, and failure of conservative treatment which is the criteria. We should not think about the age, we should think about the prior treatment which the patient has received and what is the stage of disease. In knee we have something called KL classification, Calculus Lawrence classification. That is a bit technical, but in your X-ray report you will always see mild, moderate, severe. If you see moderate and severe, you should have an inclination towards advising surgery. So, why I brought this X-ray was, you can see this patient, very severe very severe deformity. You can see the knee. Virtually there is no knee. There is no knee. The femur is totally destroyed. The tibia is totally destroyed. When I opened this knee, I found that there was no proximal tibia. Proximal tibia was totally gone. And these are the X-rays of this patient post-surgery, both the sides. And this is the left side, this is the right side. And this was done hardly like 1 month ago. And this patient is walking. This patient was bedridden for almost 1 year. These are the implants for revision surgery, not for primary surgery. In primary surgery, we never use these implants. But in this patient, we needed these implants for primary surgery. This is a partial knee replacement, which is advised for younger patients and unicompartmental osteoarthritis, only on one compartment. Osteoarthritis of the hip, it follows the same principles or same guidelines as osteoarthritis of the knee. If it is advanced, if the patient has not benefited from conservative treatment, then go for surgery, whatever the age of the patient is. Don't worry about, now people generally come to us and ask us whenever we advise hip replacement or knee replacement, that what is the survivalship rate of hip replacement and knee replacement. Usually, knee replacement survives for approximately 20 to 25 years, whereas hip replacement survives for approximately 20 to 30 years. This is the usual, standard usual thinking. But it can survive longer also, and it can survive shorter also. Sometimes the hip fails in 5 years only, whereas sometimes I have seen hips survive for 40 years also. So it varies from person to person. There are so many things, there are so many criteria which decide how long the implant will survive. But that should not be our deciding factor. Our deciding factor should be the disability for the patient, the pain for the patient, and whether he has benefited from conservative treatment or not. Age should not be a criteria when deciding about the surgery in osteoarthritis of the hip patient. So these are all bilateral hip patients. You can see this was a guy who came from, he was a doctor, he came all the way from Uzbekistan. Both his hips are gone, and this was done I think 6 months, 7 months ago. We did both the hips in the same sitting, and he is a very happy patient. He still keeps sending his videos when he's going to park or whenever he's traveling. And he keeps sending patients also to our hospital very frequently. Rotator, now we are talking about some other conditions which have become very common these days. Rotator cuff tears of the shoulder. So many patients will come to you with the MRI showing a complete tear or articular surface tear or bursal surface tear. So just assess the patient. If the patient has mild pain and not too much limitation of function, then just tell the patient to continue conservative treatment like physiotherapy, painkillers, and wait and watch. If the patient shows signs of improvement, surgery is not needed. On the other hand, if it's a full thickness tear, if it's an articular surface tear which is not healing, patient is getting a stiff shoulder, the stiffness is increasing day by day, then obviously surgery is going to help. Now, sometimes rotator cuff tears, even after surgical treatment, like I would say 70-80% patients, they do very well. 20-30% patients, they still keep complaining for many months. And the chances of re-tear are also there after this surgery. But if the patient is already debilitated and is not able to, is basically needs to take painkillers every day, gets, wakes up at night with pain, not able to sleep properly, and all these things, they necessitate, whatever they, be it 75, 80, 85, you should advise a surgical treatment. The first line of treatment is arthroscopic rotator cuff repair. Fractured neck of femur. So again, just like in the trochanteric fracture, fractured neck of femur is a very common condition, and it is also kind of unsolved fracture. It is also called fracture of non-union. And remember that this is the only fracture, only condition in which you should always advise surgery. Always, 110%. Because it will never unite if you don't operate. Now what you do, it depends on the duration of injury and the age of the patient. If the duration of injury is more than 3 weeks, and if the age of the patient is more than 60 years, then always a hip replacement. It might be a bipolar, it might be a total hip replacement. If the patient is less than 55-60 years and the duration of fracture is less than 2-3 weeks, then you can suggest fixation with cancelled scaleral disc screws. But at the same time, you should warn the patient that it might fail. In case it fails, then the patient might need a hip replacement at a later date. Meniscal injuries of the knee, again a very hot diagnosis and hot topic these days. Meniscal injuries, now I'll just give you the bottom line. Meniscal injuries in a patient who is elderly and who already has pre-existing osteoarthritis, don't advise meniscal repair. Pre-existing severe osteoarthritis. Then tell the patient to bear with it or try to undergo rehabilitation, and when things come to worst, then undergo total replacement. On the other hand, if it's a young patient or the patient does not have osteoarthritis, documented osteoarthritis on X-ray, then always meniscal repair should be advised. Now 10-15 years ago, the emphasis or the standard surgical procedure was removal or excision of meniscus by arthroscopy. Nowadays, nobody removes the meniscus unless extremely necessary. 99% of times we try to save the meniscus, we try to repair it. Because whatever state the meniscus is, even if it is not perfect, even if it doesn't have the perfect outline or anatomy like a normal meniscus, still it saves the cartilage from deteriorating or degenerating. Last condition, spondylolisthesis, that is slipping of vertebra. And spondylolisthesis is one condition. Now there is a grading. So 1, 2, 3, 4, 5. Grade 1 is like 0 to 25, grade 2 is 25 to 50, like this. So more than grade 2 surgical, less than grade 2 conservative. But if a patient who has less than grade 2, say between 25 and 50%, and still the patient is not getting relief from conservative treatment, then go for surgical. Otherwise, mostly more than grade 2, you should always advise surgery, spondylolisthesis. Now it depends on the patient. 60-70% of patients I know, for spine surgery they will not agree. Even if you keep kind of forcing on, counseling them that you need surgery, still the patient will not undergo surgery. But logically, more than grade 2 listhesis, surgical treatment, less than grade 2 listhesis, conservative treatment. So this is the conclusion. I've just tried to make this presentation to make it easier for you to understand that if you refer a patient to an orthopedic surgeon, and if the orthopedic surgeon advises surgery, then you should be able to judge yourself whether his advice is correct or financially driven. So basically, no universal approach, individualized treatment planning. One size does not fit all. You have to think about the patient, functional status of the patient, age of the patient, the stature of the patient, whether it's obese or thin. Then balance between surgical intervention, conservative treatment. continuous patient evaluation follow-up. So these are the things which make us look more towards the surgical treatment, emerging technologies, minimally invasive techniques, and personalized medicine approaches. So thank you very much. It is
thank you, Dr. Abhishek, and thank you, Dr. Vineet, for two wonderful sessions. We'll start the question answer session for the first talk. Dr. Poddar sir, your perspective on Dr. Vineet's talk first.
So I think Dr. Vineet said already during his talk that he already discussed URILOFT procedures. URILOFT procedure for BPH, but it is very costly, as he said. And he said lesser invasive procedures are available like REZUM and implantation procedure. So my only concern is when you advise REZUM procedure, so do you rule out malignancy just by MRI or just you do PSA and ultrasound to rule out malignancy, and you are of course your digital examination.
So the standard protocol is to do a DRE and a PSA. If the PSA is not elevated and the DRE is normal, then we consider the risk of prostate malignancy to be minimal. There are certain varieties, less than 1% incidence of anaplastic CA, which may have a lower PSA, but otherwise it practically rules out the possibility of having a malignancy in the prostate, and we will not do an MRI in such cases prior to the procedure. Having said that, if the index of suspicion is high, then the next role will be for an MRI.
So I think this is otherwise also most of the patients, if DRE is normal, they know hard nodule, and PSA is normal, then we don't suspect malignancy in most of the cases. And cost, you said I think around 2 lakhs of REZUM procedure.
So we actually calculated based on the number of filings. So it's like this, that in India there's nothing like a single-use device. Though this is supposed to be a single-use device, you get 15 counts of therapy sessions on one gun. If we use about 6 counts or 5 counts on one, you're able to use this gun on up to 3 cases. Based on the fact that you are able to use it in 2-3 cases is where we can price it at about 2 lakh rupees.
And after how many years patient has to, can it be repeated in the same patient, this procedure, he has to undergo another procedure?
So it can be repeated, though recent data shows that it's not required, set to be a lifelong procedure. Vis-a-vis the other procedure which I showed, which was ITind, which is the temporary implant procedure, which is known to work for 4 to 5 years and may need to be repeated after that time.
I think we can open it for the audience. Dr. Chauhan.
Dr. Vineet, thank you for a wonderful presentation on the procedures, REZUM, the URILOFT, and ITind. I never heard about it. You mentioned something very important. When you, Dr. Saurabh, we would require your feedback because it's a surgical thing. Can you just come here and...
Sure.
Yeah, please.
Second talk I have heard, sir. What for?
No. We would still require your feedback on the URILOFT procedure, the prostate REZUM, and ITind. I thought it was something about IT, but then I see the end, so I couldn't understand. You said something very important for the benefit of everyone here. There is a very important aspect to someone's life who is getting operated for prostate, and that is the sexual life. Now if someone says at the age of 75 years that I am still sexually active, what modification will you do in surgery and which part you try and retain so that the prostatic secretions, bhai sun lo bhai please, so the prostatic secretions are maintained?
So, excellent question. So the important thing is if I'm doing a laser procedure, then there is a modified procedure which we call is ejaculation preserving laser prostate removal procedure, where we maintain the area around the valve. So we know that the ejaculatory ducts will open onto the verumentanum and they traverse through the prostate along the apex. So this is the area that we will preserve when we are doing a laser ejaculation preserving procedure. But we've actually gone beyond that, because even with this, there used to be two issues. You would have to leave tissue behind, and this central tissue is actually a fairly important tissue for the urination also, so the patient would not be fully satisfied. Now with the REZUM procedure, you are actually able to completely dissolve this part of the prostate. You actually flatten out the bladder neck without actually causing retrograde ejaculation. And since it's a very slow process, the process of completion of REZUM and its dissolution of prostate actually takes up to 3 months. So the patient has this ability to actually overcome any ejaculatory disturbance that he may feel initially. So it's actually a very slow growing process that happens in the prostate.
Sir, I understand that you will be leaving behind some glandular tissue which will have the secretions. But is there not an inherent risk of leaving the very tissue which is amenable to malignancy?
So the malignancy generally originates from the peripheral gland. And the one that we are leaving behind is usually transitional and centrosome, not the
So
peripheral.
there is no issue of that.
No.
That has to be clarified to everyone. You are retaining the tissue which is not amenable to malignancy.
Yeah.
Right. Sir, you mentioned some wonderful procedures. I have heard your lectures on the basic lasers and then the holmium laser. What we have to understand, friends, is that when you are using these technologies, they need to be excellent. But the problem is, sir, that we are causing a burning in that area, whatever laser you are using. In your experience, which laser is the best so that the residual strictures, where the patient doesn't have to calibrate every single day of his life after surgery, is not required? Whether it is holmium or it is a routine laser or something else which you mentioned, which actually I don't understand what my field. So, in your experience, which is the best laser so that the patient is not left with a stricture later on?
So the procedures which I mentioned today, none of them will leave a stricture because these don't cause heat in the passage. The steam procedure is steam well into the depth of the prostate. URILOFT is a stapling procedure, and ITind is a spring procedure. So none of these cause any heat in the urinary passage. None of them will cause any stricture. The question becomes relevant for which laser. Some of the lasers use very, very high wattage, like the thulium laser. Will cause charring, diode laser will cause charring, causes extreme heat, works at between 200 to 300 watts of energy compared to a holmium laser which can work at between 60 to 100 watts. And so the holmium laser scores much better than the others for a laser treatment of prostate. But we are moving behind. Moving beyond. There was a time when Maruti was acceptable to everyone as the car of choice, come what may. That was what was available and that was the car of choice. And now you have so many, so it's a quality of life, and everybody is looking at what else can I get. I'll have a sunroof, I'll have this, I'll have that, safety, ADAS 4, ADAS 5, whatever it is. So you're looking at what your quality of life, because that's how we're changing now. People are demanding that, we are demanding that in other fields. And this is what is changing with treatment also. You can't just say I'll treat your prostate and you'll be alright, you'll be free from prostate disease. I have to give them a quality of life along with that, and so I have to look at everything that can maintain that quality of life. This is what we are presenting.
Sir, what is the usual cost of the procedure, the 3 procedures which you mentioned? Kindly explain. REZUM, URILOFT and ITind.
So the REZUM cost for a patient, again, there will be some difference depending on the number of therapies used for that patient, so his prostate size, but will be approximately 2 lakh rupees. The cost for the ITind procedure will be between 2.5
2.5 and 2.75 lakh rupees, maybe to an extent of 3 lakh rupees in some patients. And the URILOFT procedure again depends on the number of staples used, but when we count an average of 3 to 4 staples used for one treatment, it's about 4.5 lakh rupees.
Wonderful, sir. Sir, my last question to you is there a learning curve?
That's the other brilliance about this. This actually, so a procedure is considered by the standard of how easy it is to teach someone a procedure. And all three of these procedures are extremely simple to learn and to teach.
So there will be some risk because we are not removing. So just clarify on this.
So we don't touch the peripheral zone of the prostate. So the inherent risk which remains, always remains. The question was, are we increasing the risk of prostate cancer, and we don't do anything to the risk of prostate cancer. But the inherent risk will always remain. So as a general fact, we follow up with annual PSA beyond a certain age, and that will remain for anybody who's been treated or not treated for prostatic disease.
Thank you for clarifying. Your peripheral zone is not removed by laser or TURP, whatever procedure. That is the area where cancer occurs. That inherent risk will be there. Thank you.
Thank you for clarifying. Yeah. Before I go to the masters, Dr. Tulsi and Dr. Kalra sir, so just a hypothetical question. We keep hearing these days about arterial embolization. We also know that in Vedanta and in ILBS, they are treating liver cancers, solitary cancers, multiple cancers by techniques like trans-arterial embolic embolization. Is hypothetically this trans-arterial embolization possible for prostate, for BPH, so that we can just embolize the artery and finish the story off?
So there is treatment which is used for TAE of prostate also, unfortunately, as it is for varicoceles. The problem is that this is a fibroadenomyoma, and you will never treat the complete prostate by arterial embolization, and so it's a failed procedure. I mean, it's been decades when it was abandoned as a procedure itself. There are certain procedures which have come and gone and should be in the realms of history rather than in current practice. It actually occupies that space.
Dr. Tulsi sir.
Once again, such a nice talk, Dr. Vineet. Always a pleasure to listen to you. So the evidence of next treatment is growing, but some uncertainties remain as to the magnitude of the advantages and disadvantages. So I'm referring as compared to the TURP, which today again is the gold standard treatment, but Polar property is coming in a big way today. So when you are talking about minimally invasive surgeries, especially which you talked about URILOFT and REZUM and all those things, so the biggest advantage is the preservation of erectile, dysfunctions and things like, sexual dysfunctions, etc. there. But we talked about the gold standard remains the TURP, and between TURP and bullet, what would you prefer?
It might go, but it might be. Hello.
ऑन करिए चल रहा है
ऑन है इसका वॉल्यूम थोड़ा बढ़ा
बोलिए
Sir, absolutely true. We are talking about specific indications here. We don't do a REZUM when the gland size is more than 80 degrees, 80 grams, and we don't prefer an ITind. ITind is still a very recent procedure. This is actually a temporary placement of a implant which will result in immediate relief. So it's like a stopgap procedure used in very sick patients. URILOFT again has its limitations. TUR and HOLEP can be done in all prostate sizes. URILOFT has a far greater advantage over TUR because the side effect profile of a holmium laser procedure is far lower than TUR because For irrigation, we use normal saline compared to glycine, which needs to be used whenever an electrosurgical unit is used. So we have a completely safe procedure which can allow a normal like enucleation of the gland can be used in gland size of 20 grams to 600 grams. The TUR can't be done, usually should not be done in gland sizes greater than 120 or 150 grams for the fact that then the risk of TUR syndrome becomes significant unless you are using a bipolar electrical surgical unit. So there are a variety of factors and one size does not fit all. I think this was used in the treatment. That's how it exists.
How common is the TUR syndrome? Hyponatremia, electrolyte imbalance. Have you seen
With
them?
large, oh yes, absolutely. Early on in our training days, we used to see a lot of them.
Now,
Because of the fact that glycine was used and TUR was done. Nowadays, bipolar is done, you use normal saline, so the incidence has dropped tremendously. Extremely rare to get TUR syndromes now, though you can still get them. If the capsule has been opened in enough areas, then you will get them.
absolutely. So, Dr. Chauhan talked about PAE. So, this seems to be, this is recently added to the American Urologic Association standard of care and guidelines. Very safe and effective treatment, dramatic effects on quality of life. Just a word on the PAE.
So I have already given my words on PAE, they should be historical rather than current practice. Some of the things, so I'll tell you, example is
Recently,
some of the things in US FDA practice, like something like HIFU or thermotherapy, is that US is insurance-based system. And a lot of their treatments, they use green light laser, which we've abandoned in practically all treatments of prostate. So you have to read through what is being used and for what indication is being used. A lot of it will be insurance driven, so let's not do that.
right.
OLEP versus TURP, I don't think TURP should be gold standard now. OLEP should be gold standard now.
Why?
He said
Tell us the difference between the two.
they know that
Significant less reduction in blood loss, and what about catheter? Probably you need
you
to
can remove the larger glands also by OLEP.
apart from that, what about the catheter? See, it may be 5 to 7 days in TURP as compared to just 1 or 2 days in a whole.
So we actually don't keep the catheter for greater than 2 days by whatever way we treat.
Even in TURP?
Even in TURPs, but we don't do TURPs now.
OLEP is gold
The fact is
All
that
it is like gold standard now?
Yes.
Yes.
Wonderful.
Yes.
Dr. Abhishek?
No, no.
Yeah.
First Dr. Vineet.
Okay.
First Dr. Vineet.
सर इतने सारे सवाल उन्होंने पूछ लिए मेरे सवाल तो फनी ही हो सकते हैं जस्ट लाइक शमा मोहम्मद हैड आस्क्ड समथिंग सर मैं ये कहना चाहता हूँ जैसे नोएडा में सुपरटेक की एक नॉर्थ हाई करके एक बिल्डिंग थी उसको उन्होंने ब्लास्ट किया था सो यू आर डूइंग इन रिज्यूमे सिमिलर ब्लास्टिंग एंड डज इट अफेक्ट द नेबरिंग structures?
So actually the needle length, if you see, is 1 centimeter only. It goes a centimeter inside the prostate and then discharges the steam. The steam is contained within the capsule, so it does not extend beyond the capsule, which is why this is a contained targeted treatment.
Sir, monoclonal antibodies are coming in a big way in every field. Do we find any place in this field?
So malignancy, yes, not yet without malignancy, but I am completely with you. I think we will be treating disease by altering proteins and genes rather than doing treatments, and most treatments will be preventive. There are some movies which talk about preventive killing of criminals. Like that, we will be preventively preventing the diseases by identifying proteins which alter and cause the disease. I think that's the future.
They are identifying for MI also.
Everything. Proteomics is how we proceed, but it's not here right now, sir.
Thank you, sir.
2035 वाला जो सर का talk होगा वो उसी पर बैठेगा.
We had a very futuristic talk by Dr. Abhishek Mishra, whether it was by design or by mistake. Dr. Abhishek Mishra at 2035. So there are two things he is praying for. One is that all of you are still here when he gives us the next presentation. And the second thing is that he is so futuristic that he is absolutely sure what he is talking about today will hold true till at least 2035. I would give the mic to Dr. Prateek Singh. He would give us the perspective on the talk by Dr. Mishra and some of his questions.
Very nice talk, sir. All the points which Dr. Abhishek has stressed upon are relevant to the general practice also. There are certain things which are could not be covered in the limited time. One is the general question which every doctor faces by the patients, that in this fracture, what we are going to use, plate or the nail? This is the most common question which everyone faces. And patient usually do the window shopping also, go to this surgeon, that surgeon, and go to the family physician also. So I would suggest.
I'll give you a very simple answer.
Yes, sir. And the second.
You just say, the patient asks you, just say, I'll use rod. Rod can be a plate or a nail.
Exactly.
Show the X-ray.
My question is, sir, I would request, sir, because the what physician should know, what are the benefits of the plates and what are the benefits of the plates. So
Not necessarily should know.
No, so actually I'll tell you, so when we talk about technical thing, now there comes a difference between load bearing device and load sharing device. A plate is a load sharing device and nail is a load bearing device. Whenever there is an elderly person, osteoporosis, load sharing device should be preferred. That is a nail. Most of the fractures. I wouldn't say 100%, but 80-85%. And whenever the patient is young, and then of course there are personal choices, like what you are more experienced and what you are more familiar with. So if I'm a physician and if a patient comes to you, and if you ask me, plate nail usually patients don't know. I mean, they didn't used to know. They didn't know like a couple of years ago. Now the patients have started knowing in 5-10 years. My practice ko almost 20 saal ho gaya, so I know a little bit. So just combine them, say rod dalni hai isme. Rod mein koi patient nahi puchega, plate dalega ya nail dalega. Basically metal implant dalega, that's it. As a physician, if I would be a physician, I would say this rod dalega. Which means second implant has to be put.
Should leave it to the
Yes.
Dr. Abhishek, you showed some wonderful X-rays of the spine and some vertebra where you did kyphoplasty. My question is, if somebody has multiple vertebra with osteoporotic fractures, how many vertebra can you do kyphoplasty, and what is the substance that you put in?
Sir, multiple vertebra, firstly we should rule out whether it is actually just osteoporosis or a procedure like myeloma or secondaries. That is the first thing. So we should be particular that we should be taking out biopsy when we are doing a kyphoplasty. Biopsy should be read to the patient should be prognosticated, and relatives should be explained. That is the most important thing. And there is no limit to how many vertebrae you can do. I have personally done, Dr. P.K. Gupta is not here today, but one of his relatives, we had done like 8 vertebrae in the same sitting. And he had myeloma. And he lived for many years after that.
What substance do you put?
So it is just a bone cement like we use in BHO care. It's called Subuton. Subuton is actually a trade name, but the viscosity is really different from what we put in knee replacement, hip replacement. But it's more or less the same thing.
You emphasize that the intertrochanteric fractures must be handled by surgery. Never going for conservative management.
Never until unless it is a paralytic patient or is a patient who was already bedridden for many years.
Very good. Good passage for all of us. You also mentioned some of the fractures in the upper limbs like the Foley's fracture, which can be equally well managed conservatively
without surgery.
Without surgery.
90% without surgery. 95%, 99% without surgery.
Right.
Foley's fracture.
Right.
But one should be able to differentiate between Foley's fracture and an intra-articular distal fracture, which superficially they look the same, but there is a great amount of difference between these two. So Foley's fracture, the traditional teaching is called dinner fork deformity. Dorsal shift, lateral shift, impaction, supination. These are the 6 typical displacements in a Foley's fracture. Whereas the intra-articular fracture, it tends to affect younger people more commonly, and it should always be treated by surgery. Foley's fracture, surgical treatment has no role.
I would like to ask you the final question from my side. in a young person below 18 years of age, if somebody has a supracondylar fracture in the upper limb, and we know that the cartilage is still not united. So what management should be done? Family is saying we want a conservative management, but we know that this is going to grow. So would you like to bet on a conservative management if you can actually put the things in place, or would you still like to go in for an intervention?
It depends on the age and it depends on the grade.
18 years is the age.
18 years supracondylar fracture should be operated. But supracondylar fracture, I think, sir, what you are meaning is supracondylar fracture is more common in adolescents, like 7, 8, 9, this year.
That's right.
And if it is a grade 1 fracture, you can manage just with a plaster. Grade 2, grade 3, severe displacement, skin puckering or some neurological involvement, 100% surgery. So more than grade 1, it should be operated.
Thank you.
To avoid cubitus venous and other complications later.
Thank you very much, sir. डॉक्टर मैंने डॉक्टर सौरभ को बुलाया था सवाल पूछने के लिए और let's hear it for Dr. Saurabh Bansal यार एक बार. Our gastro surgeon.
Sir, I know you are a wonderful TKR surgeon, and I want to know, because your talk was very interesting. I heard half of the slides. What are the patients whom you yourself are not very keen that they will be really doing good after TKR? And what are the patients? Actually, we should like, for sake of us, people come and ask. This is the most common problem in any branch. People go, मेरे घुटने तो घुसते हैं जी, बता दो ये किसको कहाँ जाना है?
I totally understand what you're saying.
Yeah.
So I tell you, there are two groups of patients.
Close friends.
ये probably नहीं सर, close friend में check करते हैं. Close friend में check करते हैं if they are determined. It depends so much on patient's willpower. So अगर patient के X-ray में कुछ gross सा नहीं दिख रहा हो, मतलब बहुत खराब नहीं दिख रहा हो X-ray, जो जितना बुरा होगा ना पेशेंट, जो जितना खराब होगा एक्सरे में और अदरवाइज, वो उतना अच्छा करेगा, उतना सेटिस्फाइड होगा. जो जितना कम खराब होगा, वो पेशेंट बेसिकली रिलेटिविटी वाली थ्योरी है कि आप -5 से +5 जा रहे हो या 0 से +5 जा रहे हो. -5 से +5 वाला ज़्यादा कुछ होगा. जो मोरलेस ओके है, और उसको एक दो लोगों ने टीका एडवाइस किया हुआ, एक्सरे ठीक ठाक लग रहा है, एमआरआई भी ठीक ठाक है, एक्सरे में कहीं कुछ अनइवन सा नहीं लग रहा है, should not advise surgery. इंजेक्शन दो, वेट लूज, ये फलाना ढिमकाना. दूसरा वो पेशेंट अच्छा नहीं करते हैं जो मोटिवेटेड नहीं होते हैं, जो 10 डॉक्टर के पास जा रहा होता है, 15 डॉक्टर के पास जा रहा होते हैं, और जो डॉक्टर बोल देते हैं ना कि बिना सर्जरी के तुम्हारा काम चल जाएगा, वो उससे चिपके रहते हैं. पर बीच में सुनने के लिए नहीं कि दूसरा डॉक्टर क्या कह रहा है, 3 महीने में तो आपके पास आ जाएंगे. ऐसे पेशेंट को भी सर्जरी एडवाइस करो तो बोल दो कि भैया तुम्हारी इलाज सर्जरी है, नहीं कराना मत कराओ, लेकिन कराओ तो मोटिवेटर कराओ. मोटिवेटर कराओ. Honestly, there is no criteria. Rheumatoid people as young as 18, 17, 19, they need hip replacement or knee replacement. Actually, 24. Higher side, 93 is the oldest I've done bilateral knee replacement. Bilateral knee replacement, 93.
There is no limit to it.
There is no limit. It's more about physiologically.
Fitness.
Sir, PRP is given in few patients when they are very pain in their shoulder.
Great.
How it acts?
So we are talking about shoulder, we are talking about knee, sir. So shoulder, rotator cuff tears, bursal surface tears, not articular surface. रोटेटर कफ का एक आर्टिकुलर सर्फेस है सर, एक ऊपर वाला सर्फेस है. ऊपर वाला सर्फेस का टेयर है, बहुत फुल थिकनेस टेयर नहीं है, पीआरपी 100% काम करेगा. अगर आर्टिकुलर सर्फेस टेयर है, फुल थिकनेस टेयर है, तो पीआरपी बिल्कुल काम नहीं करेगा.
It is taken from the same patient and then.
Yes. So you.
How much blood is taken?
Sorry, sir. So you just withdraw blood, जैसे blood sampling में करते हैं. 20-30 ml blood लेते हैं. बहुत सारे तरीके हैं, सेंट्रीफ्यूज मशीन होती है, उसमें आप सेंट्रीफ्यूज करते हो. So 20-30 ml blood से आपको 3 या 4 ml आपको मिलता है कॉन्सेंट्रेट. वो APC और Orthopaedic कॉन्सेंट्रेट या PRP कहते हैं उसको. आजकल GFC किट्स मिल लगे हैं, वो ग्रोथ फैक्टर स्टिमुलेटिंग GFS. सो बेसिकली वो प्लेटेड टाइप के होता है. सो 20-30 ml ब्लड से आपको 3-4 ml वो PRP या GFC मिलता है, वो आप पेशेंट के अंदर इंजेक्ट कर देते हो शोल्डर में या नी में या जहाँ भी wherever you need it.
It will be a permanent kind of thing. Yeah, after some time we need something.
So permanent, nothing is permanent. It depends on, it varies from patient to patient. So whenever you are using a PRP, you should always explain to the patient that effect might be everlasting, or it might last for a few months. It might last for a few years. So very important is communication. You have to explain to the patient.
You have a question, Vineet?
No.
Dr. Tulsi, sir.
What a nice talk, Abhishek. So, surgical interventions versus no intervention, just a medical or conservative treatment. Talk us about the success rate of L4, L5 fusions in spinal stenosis, in disc degeneration, multiple fractures and herniated discs. It's just about 50%. And 10% of the people may experience worsening symptoms. L4, L5 fusions, sir.
Sir, sorry, worsening symptoms, I would not agree. The symptoms never worsen. It's about the expectation of the patient. If the patient is expecting recovery, and if it is not recovering, then he or she would say that it's worsening. It never worsens. It might not improve. I'll tell you the conditions. The most important condition according to me is if the patient has a multiple level disc degeneration. Suppose patient का ना L5S1 disc या L4 L5S बहुत बुरा है, और उसको साथ में L3 L4 भी है, L2 L3 भी है, जुगला.
Multiple levels. Yeah.
So generalized disc degenerative disease है. वो patient कभी भी 100% they never improve 100%, and you have to prognosticate.
Why I said that was because the microendoscopic discectomy success rate is as good as 90%.
But sir, I'll tell you, if you just go through the literature, there is approximately 20 to 25% of rate of recurrence after the microscopic discectomy also. So sometimes I also don't even tell my patients. अगर मुझे लगता है पेशेंट को जरूरत है तो मैं ये बताता नहीं हूँ. वो पेशेंट जब 5 साल 10 साल बाद आता है, जब उसका डिस्क रिकर कर जाता है, so you can just go through the literature. 20 से 25% चांस होता है रिकरेंस के.
Right.
एंडोस्कोपिक डिस्कटमी के बाद भी.
My last question would be regarding the laminectomies and the discectomies for sciatica. We see this so often, 90% success rate if the pain is beyond 6 weeks. How often do you do that, sir?
So that is a criteria.
Laminectomy, discectomies.
That is a criteria. So what we say is red flags. So red flags is significant neurological deficit which might be sensory or motor or bladder or bowel involvement. So these are the main criteria.
Pain persisting
for more than 6 weeks despite conservative treatment. That is another very important thing.
And the success rate is as good as 90%? Would you say that?
Success rate is as good as 99%.
99%. Wonderful. Thank you, sir.
Thanks.
Sir, I'm the last daba of the train. Just ask 2 questions, sir. First is, how common is fat embolism? Have you seen in your practice? In fracture, fever, and all that?
It's quite common.
Can you do something to prevent it?
So I had a young boy, sir, I will tell you, this was when I started my practice only. I had operated on him at Holy Angels Hospital, there was a spondylosis. Young guy, Christian, bilateral femur fracture. I had operated on him in 1 sitting and he was discharged. Like second, his budget was less, so I discharged him next day. उस समय दिमाग में वो सिर्फ दूसरे दिन से काम कर रहा था. He came back second, third day with and he was sent to ICU in Fortis. He recovered. And not only one, like we have seen 2-3 more patients. Fat embolism is quite common, especially after long bone fractures. Fat embolism is not so common after joint replacement. After joint replacement, pulmonary embolism, PE is more common. It might be a small PE, disseminated PE, whatever. But fat embolism is quite common after long bone fractures, especially multiple long bone fractures. So you have to be very careful. There is no specific एक ऐसा कुछ रामबाण नहीं दिया हुआ है कि ये करके आप fat embolism prevent कर लोगे. But generally, giving steroids and blood thinners.
Which makes it probably more common?
Yes, of course.
So where
Yes.
there is fat,
110%.
this fat in body fat is
Coming
coming
from
from the muscle.
Yes, marrow.
Comes from marrow. Sir, my
Because
last,
the reaming, you are putting it, sir.
my last half question is, what is the guideline for patella fractures? How do you manage them? What is
Undisplaced fracture can manage conservatively. मतलब सिर्फ फ्रैक्चर लाइन दिख रहा है एक्सरे में, पर फ्रैक्चर हिला नहीं है बिल्कुल भी. मैनेज कंजर्वेटिवली. अगर जरा भी हिला है 110% ऑपरेट, चाहे वो 20 साल का हो चाहे 90 साल का हो, क्योंकि वहाँ उसके मसल के फोर्सेस लग रहे हैं, तो वो कभी भी उसको अपनी जगह पे रिड्यूस नहीं होने देंगे.
Friends, we had two wonderful sessions by two wonderful speakers who are well known to us, and thank you very much our moderators, Dr. Prateek and Dr. S K Poddar, to do a wonderful work. I would like our speakers and moderators to come here, Dr. Kalra sir, Dr. M. K. Gupta, Dr. Sugrit, the big boss, the CEO of IAMS, Dr. Saurabh Bansal, our gastroenterologist surgeon, and Dr.